Okay, well, good evening, everyone, and welcome to this BAJIS webinar on periprosthetic joint infection. Tonight we have three excellent speakers, each with a vast amount of experience and knowledge, and they're going to be presenting some very interesting topics, so it looks to be a great session. Before we dive in, if you've got any questions during the presentations, please post them in the Q&A box at the bottom of the screen. I'll do my best to address these during the session. So to kick things off, it's my pleasure to introduce our first speaker, Dr. Michael Neufeld. Mike's a revision hip and knee surgeon from the University of British Columbia in Vancouver. He stepped into the big shoes of Dr. Clive Duncan when he retired, and he's already established himself as the go-to expert for PGI in British Columbia. Tonight, he's going to be addressing the ever-important topic of PGI prevention. So over to you, Mike.
Great, thanks a lot for the introduction. Okay, you can see my slides there? Okay, I'll dive into it then. All right, thanks for having me. My disclosures, none are relevant to today's talk. Oops, this. As we all know, periprosthetic joint infection, it's devastating. It's the leading cause of revision in a lot of joint registries, including our Canadian registry. And unfortunately, despite a significant amount of scientific effort, we're not really reducing the rate of periprosthetic joint infection when looking at the literature. There's some literature to suggest that it's increasing. With the increasing number of joints that are being performed in North America annually and what's expected to increase, this is going to be a huge problem and continue to be a huge problem for the healthcare system economically, as well as patients who are suffering. There are many different avenues that you can kind of look at and target to try to combat periprosthetic joint infection. I would say that prevention is probably the best strategy. It'll never be zero, but trying to even making a little difference in prevention will go a long way given the number of joints that are being done. Okay, so there are several good review papers, a lot of novel work being done. There's a lot of experimental work being done, which I won't touch on a lot of that today. Today, I'm going to talk about some select high-impact strategies that are practical in clinical practice that you can take home with you. Okay, so in terms of preoperative interventions, obesity is always a very hot topic. What's very clear is that obesity, especially if you're morbidly obese, your rate of all surgical medical complications are increased, including periprosthetic joint infection. However, in these patients, regardless of their BMI, the improvement in functional outcome scores are similar for all patients, right? So you need to keep that in mind while making things such as BMI cutoffs. BMI cutoffs are controversial. They don't know if BMI is the best marker. Certainly, if you had a BMI cutoff of 30, your rate of periprosthetic joint infection would be reduced compared to a surgeon who operates on patients with BMI over 40, but you'd be blocking access to complication-free joint replacement for a large proportion of patients. So you really have to think about that, and there's ethical considerations there as well. In terms of bariatric surgery, it depends on what study you want to look at. Some studies show this works, others don't. It's inconclusive, certainly. And with preoperative weight loss, there's a lot of literature looking at this recently, and it's conflicting evidence. One thing that's very clear is that if you just tell a patient to lose weight and they do it through calorie restriction alone and they lose weight rapidly, they'll actually have a higher rate of periprosthetic joint infection versus those patients who didn't lose weight. So it's more than just weight loss alone. And that comes to my next point here, whereas this is not a simple problem that orthopedic surgeons alone can take care of. We have specialized teams here in BC, Canada, who we're able to refer these patients to a multidisciplinary approach. And they look at malnutrition, sarcopenia, several markers of metabolic health that are kind of outside of our area of expertise in terms of optimizing these patients before surgery. I think the GLP-1 receptor antagonist, there's a lot of research and a lot of promising data showing that use of these medications will decrease the patient's BMI. And there's also studies showing the reduced rate of periprosthetic joint infection if they're used appropriately. This is early data, it needs to be validated, but this is something that's going to be part of the multidisciplinary approach for these patients, I think, for sure. Obesity is a problem that's not going to go away. It's a huge problem in North America, and the research in the future, you need to look at these care pathways and you need to evaluate guidelines and policy to see what's actually working and what's not. Okay. In terms of nasal decolonization of Staph aureus and skin decolonization, there's conflicting evidence, but randomized trials and systematic reviews show a decreased rate of superficial site infection with this technique, and periprosthetic joint infection maybe for those who are Staph aureus colonized. Okay, what is clear is that universal decolonization is the best strategy, not screening and targeted strategy in terms of being cost effective. And there's been a lot of interest in nasal photo disinfection. The bottom line with this is that there are some advantages of mixed literature, but it's definitely not superior to skin wipes and mupirocin in terms of reducing the rate of periprosthetic joint infection or superficial infection if you can't use this in your hospital. Okay, I think this is a very important one. Diabetes, hemoglobin A1C, and blood sugar control. If a patient's hemoglobin A1C is above 7, their risk of infections increased. If it's above 8, it goes up exponentially, right? So this is something where a cutoff makes sense. Literature would say less than 7 is a good cutoff to reduce the risk of periprosthetic infection. I have a cutoff of somewhere around 7.5 in my practice. This is actually easy to do. You screen and you refer them to a endocrinologist or back to their family doctor, and they will be able to get their hemoglobin A1C down. It's much easier than weight loss or smoking cessation. So this is something that in your practice, if you're doing, you will definitely reduce the rate of periprosthetic joint infection. In the futures, there's markers such as fructosamine that may be better markers, but we need more data on how to use this in clinical practice before doing that. What I want to say about a blood conservation program is that your goal in primary joint replacement should essentially be 0. And for most revisions, you could identify people who have low hemoglobin preoperatively, and you should refer them to be optimized because, as we know, transfusions are associated with periprosthetic joint infection. If we can eliminate this from the majority of our practice, we'll be helping our patients substantially. In terms of intraoperative interventions, this is very important. It's been shown over and over that ANSAF is very important for preoperative antibiotic prophylaxis, a weight adjusted dose. And the key here is that our institution in Canada, that penicillin allergy patients always received vancomycin or clindamycin alone and not ANSAF. And it's very clear now that ANSAF is safe in these penicillin allergy patients. And there's data to show that if people have cephalosporin allergies, that allergy testing is cost effective in these patients. Okay. This is probably one of the most important slides. I don't know the routine practice everywhere. When I was training, this was still done in some of the facilities that I would train in. I'd say there's no role for withholding antibiotic prophylaxis prior to the second stage revision in periprosthetic joint infection. You have very minimal effect on culture yield, and your absolute risk of introducing a new infection with this big revision surgery by holding prophylaxis is high. So it's just a practice that shouldn't be done anymore. In terms of skin prep, it seems that alcohol-based chlorhexidine is the best for preventing periprosthetic joint infection. There's strong evidence, level 1 evidence in other areas of surgery, and total joint replacement is not unanimous. Betadine seems to be a good alternative if they're chlorhexidine allergic. TXA use, no, I think everywhere. This should be the standard of care in primary and revision joint replacements. Decreases blood loss. There's other data to show it helps with functional outcomes after knee replacements. Certainly, it's associated with a decreased risk of periprosthetic joint infection, so it's something that should be part of your standard of care. Irrigation solutions, you could talk about irrigation solutions for probably an hour and get almost nowhere. The most recent systematic review and meta-analysis showed that dilute betadine reduces risk of periprosthetic joint infection versus normal saline. However, there's certainly conflicting evidence, and this is definitely inconclusive. What's clear is it's not harmful, and we need a definitive large trial on this, which would be a Herculean effort given the low infection rate and the number of patients that you would need to enroll. There was one RCT by Craig Della Valle and his group that showed in aseptic revisions dilute betadine reduced the rate of periprosthetic joint infection at 90 days. So I think based on the current evidence, it's reasonable to use in revisions in high-risk patients, but there's no data to say you absolutely have to use it. We tried to do a 4-arm randomized control trial looking at vancomycin powder and dilute betadine out of New York. This was presented at August. They stopped it early because there were no differences in any outcome at 800 patients. The numbers needed would have been too high to be feasible in the trial or meaningful, and it is up to surgeon discretion. The good news is that Tom Wood out of Ontario and Canada, McMaster, he's done the pilot study, and they're starting a large prospective international randomized trial with over 10,000 patients where they'll be looking at dilute betaine versus normal saline. So we may have the answer when this is done. I think in terms of novel irrigation solutions and therapies, there are a lot of them. I think that this is going to be this is an area where you can really make a huge difference in periprosthetic joint infection. I think trying to prevent biofilm and then break it up once it's established is going to be the way of the future. So I think you have to stay tuned to see what's happening in this field of medicine. In terms of operative room traffic during the surgery, there's many studies showing that increased traffic, number of people, and how often you're opening and closing the door increases contamination in the OR and the air, as well as equipment and gloves. Right, so you need to make this a priority, reduce operative room traffic in your practice. There's good recent articles on strategies to do this. Intraosseous vancomycins received a lot of attention. This was a 2021 study that won an award that showed decreased risk of infection at 90 days using intraosseous vancomycin with knee replacements using a tourniquet. They show that it's also effective in terms of getting antibiotics to the tissue in hip replacements and in knee replacements that are not using tourniquets as well. Okay, so this is fast, easy, low cost. There's many benefits over IV administration. There's a large trial that's pending, and this has potential to be practice changing, in my opinion. There was an international consensus meeting on wound closure. I'll cover some of the key points quickly. Barb sutures, there's a lower risk of wound complications if used on the skin. The patients certainly have more satisfaction with these sutures versus staples on the skin, and it's not definitive, certainly, but in the hip and knee, there may be lower surgical site infection or reoperation compared to staples, but not revision for periprosthetic joint infection. Mesh adhesive dressings, same thing, but you need to weigh this with the increased cost of these dressings and skin reactions versus barb sutures. Silver impregnated dressings show lower risk of complications. I think what the key here with the dressings that we're using is that you have a sterile seal, they're waterproof, and then less dressing changes. So we try not to do any for the first week, and then they can take it off. I think this helps reduce the risk of wound problems. Lastly, negative pressure wound therapy. If you look at all the data, it's not conclusive, but there are lower wound complications and reoperation in high-risk patients and revisions with high BMI. So this is a reasonable thing to do in that patient population. Post-operative interventions, I'll touch on 2 to 3 quickly. Extended oral antibiotic prophylaxis. Mike Meneghetti and his group, they published this. I can't remember if it was 2018 or 2019. They showed that in high-risk patients, they reduced the rate of periprosthetic joint infection with 7 days of oral antibiotics after aseptic joint replacement. Unfortunately, there's been a lot of study on this. There's been a wide pickup of this, especially in the US, and there's conflicting results with some studies showing it's working and others not. There's obviously worries with antibiotic stewardship with this practice. Systematic review recently, in the bottom line here is a strong signal that this may reduce the risk of periprosthetic joint infection. We don't know which patient population, and we need a large trial before this is universally adopted in clinical practice. Like all trials, it's hard to power these, so I would start with high-risk patients or revisions where your infection rate's higher. But it's worth considering in high-risk cases or bigger revisions in your current practice. For DVT prophylaxis, what I would say is avoid aggressive anticoagulation, aspirin when you feel it's indicated. And the key here, people who are anticoagulated, who've never had a stroke before, full anticoagulation at home prior to their surgery. Don't go back to full anticoagulation post-op day 1 or even post-op day 2. Like we've talked to our medicine colleagues and hematology colleagues. If you aggressively anticoagulate these people, full anticoagulation right away, the chances of having a wound problem, hematoma, is not small. Right, and we all know that leads to problems. If they go back, if you wait till the wound seal a little bit, you go back post-op day 3 or 4, that's a very reasonable thing to do, and you'll reduce your rate of wound problems. Okay, so in conclusion, if we can do anything, a little bit of prevention, we can make a little bit of a change by reducing the rate of periprosthetic joint infection. That'll have a huge impact on the healthcare system. And for patients, this is an area we can have a large impact. And I think that this is an area of exciting research with massive implications. So stay tuned.
Thank you very much, Mike. That was absolutely superb. You covered a lot of high impact topics there that we could all practically incorporate into our practice. So thanks so much for that. I wanted to ask you a question about antibiotic prophylaxis duration, because that's a topical issue in the UK right now. I know in North America, the CDC had advised that a single dose of perioperative antibiotics is sufficient in primary arthroplasty, despite kickback from ACUS that the evidence to support this was flawed and that 24 hours should be given. Do you think that there is sufficient evidence to support a single dose, or should we be giving these further post-operative doses?
Yeah, I don't, in terms of the literature, if you look at it, there's nothing conclusive, unfortunately, but if you look at it, I don't think that there's any good evidence to show that, 3 doses post-operatively, so 24 hours, has any difference compared to just 1 dose post-operatively in terms of antibiotic prophylaxis. So I don't think that's where the question is. I think it's reasonable to give 1 dose post-operatively. There's no good evidence to show at all that you would reduce risk by doing 24 hours. The real question is the prolonged, the 7 days versus 24 hours, or the standard post. That's the real question that needs to be answered. And it's something that should be looked into, because there's been a huge uptake based on retrospective studies, right, of prospectively maintaining database. And it's changed practice in the US. And we don't really have good data for it. And we may be breeding some resistance, and we may run into problems with that practice adopted universally, across North America without good evidence for it.
Mm-hmm. We just had a message related to that from Tamsin saying depends on antibiotic given, and obviously this is coming down to half-life of the antibiotic as well, in terms of how long that antibiotic is actually going to be killing any potential organisms that are there. So thanks for that, Tamsin. Okay, perfect. So thanks again, Mike. We're going to move on to our next speaker. So I'm pleased to welcome Dr. Vanya Gant. Vanya is an academic microbiology and infectious diseases clinician with a great deal of experience managing PGI. He leads the Clinical Infection Service at UCLH, serves on several government-appointed national committees as well. He's got a very strong academic profile covering microbiology, immunology, and artificial neural networks. He also undertakes a lot of excellent charity work as well. So I'm delighted to have him join us this evening to talk about what we don't know about PGI. Over to you, Vanya.
Mm-hmm. Well, thank you very much, Ian. I'm not sure I deserve all these accolades, but I'm going to do something a bit different, and it might sound slightly wild after Michael's very disciplined talk, but I'm just going to give this talk anyway. And this is really focused on the feelings I get, the vibes I get when I go on to various orthopedic blogs or talk to my orthopedic surgical colleagues about what the real issues are and where the problems are. So please forgive this talk if you consider some of it rather prosaic. I was at St. Thomas's, and even I have to admit that they moved on from that. But we should really always think about the lessons of the last 100, 150 years, if not longer. And we have moved on, without a doubt. But, this quote of Lister's, I think, is really great. If we could actually see bugs as we worked in the operating theatre or before or after surgery, or on our hands even, I think things would, the situation would be better. There is, without a doubt, some remaining avoidable harm in what we do to our patients, I have no doubt. But I'm glad to say that this sort of practice, you can see at the top of this picture, no longer applies. And you can see that everybody's laughing here. This is an old picture from St. Elsewhere's, I won't mention it, where everybody thought it was rather funny that when it started to rain, it rained in the operating theatre. And you can see here an umbrella being put up to keep people dry during the surgery. I mean, this is extraordinary. This is in my lifetime, I may add. And, things have got better. but this still applies. And I note that Mike did actually mention the fact that, okay, so we're doing very well, but we're not really doing much better than we were a few years ago. And clearly, this is a heart-sick moment for all of you and people like me who are interested in trying to prevent things like this from happening. And it does happen, albeit rarely. So I just thought I'd show a picture about what people are talking about on the WhatsApp group, which is a really very, very dynamic and live group of very concerned clinicians who are particularly interested in this. And, you know, the talk in the last 2 months has been about things such as boots, such as old lunches in the operating theatre block, about chlorhexidine, about the value of rather more expensive PPE and operating theatre gowns. For all I know, the person who wrote what's written on the bottom right-hand side here, you know, is actually listening to this talk as well. And this is an example, I believe, of how they roll in China in operating theatre changing rooms. And then I'll just mention a bit about laminar airflow later. You know this, of course. These are skin scales. We know that you can't really sterilize the skin at all, and that everybody, all of us, shed bacteria. You know, when we walk, when we talk, when we move, and even when we don't move. And I'm not going to talk about antibiotics really, but I think it's sobering. You know, it's rather sobering that 60, 70 years ago, this comment was being made. And I think it still applies today, to be quite honest. I'm not sure I can keep up with new antibiotics and whether or not they're any good or not. What we can all, agree on, though, is that pharma will obviously put pressure on to get you to use their products. So let's just talk a bit about variables. And I couldn't agree more with the previous speaker about trying to prevent stuff step by step, and little steps do add up to very big results. So if you look at this, you do all 4 of those things. I put actually 5 there. But let's leave antibiotic prophylaxis out of it. If you do them all, these data are really quite solid. So you get a 27% drop in post-op SSIs if you do all 4 of them. But even if you do 2, you have a significant drop in SSIs. And my point about this really is not so much that we all read the papers and we all know what the data is. My point's more about, is this what actually people do every day? And I'd like to ask every single one of you to think about, well, actually, do I do this every day? And many of you will say, well, you know, he doesn't know anything. Of course I do. And many of you will say, well, he's talking nonsense. It may be that some of you may pause for thought slightly here. I'm going to lead post-operative dressing management. I think that's a fascinating field, and I have come across far too many cases where there has been, quotes, mismanagement of the post-operative dressing with subsequent really quite disastrous developments. Let's talk about more things we can prevent. So we all know about smoking, and, 7,000 patients, that's your odds ratio if you're a smoker for SSI. But I think the really interesting thing about this paper was they also looked at people who did not smoke on the day of the surgery. And it would appear that if you do smoke on the day you have an operation, you nip downstairs for a quick cigarette, look at that odds ratio, and that is very, very statistically solid, isn't it? So my question here is, and there's more data. Unfortunately, this paper is statistically completely hopeless, but it's a really very, very interesting thing in that, again, what this shows is that you do far worse if you continue to smoke orthopedic trauma, and it all points the same way. So my question to you is, how many of you or your anesthetic colleagues will say to your patient, I know you smoke, but look, do yourself a favor, just don't smoke on the day of your surgery. It's such a simple intervention, really, isn't it? And the data are there to show this would make a difference. How many of you, for example, and I don't know, maybe all of you do, ask, especially in your elderly population, what's my patient's serum albumin? And is it high enough for me to consider it safe to do an elective operation on them? And they're 82, whatever. And is there anything avoidable I can do about that? And if their albumin is low, do I need to do even more to try and prevent post-operative infection? This is admittedly a gastrointestinal surgery, but I have no doubt at all, and I'll talk about this a bit more, that it applies to orthopedic surgery as well. So my next point here is who actually checks? Who knows on your list on a Tuesday morning, where 3 of your patients are above the age of 75? Is it you, or is it your anesthetic colleague? Is it both of you? Do you know what your patient's albumin is? Do you take it into account? So let's talk a bit more about anesthetics. I'm glad to say that anesthetists don't do that sort of stuff anymore. But do anesthetists contribute to infection? Very interesting study. So here's Dartmouth Hitchcock. It's a level 1 trauma center, 28 operating theaters. And what they did is they swabbed anaesthetists' hands, and they swabbed IV devices used in the operating theater, and they pulled the organisms off their hands and whatever they found in theater and typed them, and then matched them up to whether they belonged to those people. And also they swabbed after the end of the second case, assuming that they had a correct cleaning protocol between cases. So there were 164 cases in this. I'm not going to ask you to look at that. That's crazy. But here's the bottom line. So 12% of stopcocks, intravenous stopcocks, that were swabbed during these operations were found to be positive. And these were sterile at the beginning of the op, right? They came out of sterile packets. And 50% of them had come from the anaesthetist. So that means that the anaesthetist's hands were actually contaminating those stopcocks. And I won't bore you with why you don't want to contaminate stopcocks. And if you look at it, the anaesthetist's hands had a whole bunch of organisms in there. And I think most of us would agree about 7 of those we know to be real disaster for prosthetic joint infection. And what did they find? They found a few things such as patient's age, etc. And they found the real drivers were anaesthetists who would work in more than one operating theatre on the same day. Patients, this is not at all unreasonable and it's predictable. Patients who needed to go to ICU after the op, the age of the patient, and also the interesting thing about this paper was that it showed that at Dartmouth anyway, it would appear the decontamination between cases was just not good enough. So I showed you some stopcocks. That's stopcocks in the UK, and that's a case. I'd like to think that sort of thing doesn't happen anywhere anymore. But we all have to face this. There's not enough money. People are too busy. We have logistics failures. We come across, things like this in theatres. This is a real problem. You cannot sterilize. You cannot clean. You cannot decontaminate objects like this that either are rusted or corroded or both. You just can't. And they will carry bugs. That's just a flat plastic surface. It's had some revealer put on it, and nobody's going to be able to keep that clean and sterile. And we come across things like this. This is the broken window theory, isn't it? If you can't get it fixed, then you don't bother. So what do? You just put a notice on saying, well, just milk it. You don't even bother trying to replace it. And this is really a cultural thing, isn't it? So if we talk about anesthetic induction, this is an interesting thing. So what we did was we went and had a look at a very, very excellent anesthetist induce one patient. So if you just run your eyes down here, this is one sequence for induction. The green bits are where the anesthetist does something to do with infection control. That's page 1. And then that's what they do. Literally, this happens over about 8-10 minutes. You can see there's some gloves getting taken on, put off, and so on and so forth. So you're down to 60 different processes for the induction of one patient here. And you can see there's a lot of gloves, a lot of alcohol gel, there's some cleaning, and it goes on and it goes on and it goes on and it goes on. And right at the end of that, the patient is asleep and the operation's going on. And the anaesthetist sneezes and then just gels their hands. And this is not a criticism. It just goes to show how complex something like that is. And then what we did is we did a kind of heat map. I know it's a funny little drawing of, what got touched during that 10-minute induction procedure. And it's a whole bunch of stuff. And it goes back to the Dartmouth thing. It is so easy to contaminate your environment with this stuff. And of course, it doesn't help that a lot of, hand washing police come around and you get people with pinnies and clipboards coming around and watching what you do. And a lot of people find that really quite unpleasant, aggressive. And I quite understand that, we're not really very good. Well, those people who try and help with infection control, are sometimes viewed with some negative thoughts. The hand stuff we know, there's a lot of tools. So that's how the hands start. And these are tools to detect contamination. And you can see how easy it is to miss parts of the hands, completely. And you all know this. Laminar flow, of course. I have come across 2 orthopedic surgeons in the last month who will refuse to operate and do elective arthroplasties if there's no laminar flow. So I'm really interested in this because the big stuff says doesn't work. Okay, but it's not that it doesn't work. I think it's just not being used correctly. And I think too many people break the flow, break the current, etc. This is a really interesting story whereby what was done in this was that there was a controlled, highly filtered airflow across the elective surgery. And you had CFU counts. And what this did was, if you want, it's mini laminar air across the operative field. And on the left, you can see the probability of prosthesis infection relating to the number of CFUs per cubic meter that were found in this situation. And the right-hand one, you can see a solid black line because this thing completely controlled the CFUs as opposed to the particulate levels when this was not used. So this works. Okay, this worked, but I don't know where it's gone. I don't know whether anybody knows about it or whether it was, but I thought this was a very interesting thing. So laminar airflow does work. It's just that we use it wrong and we abuse it and then it fails. So host factors. So I was asked originally, I think by Dominic, to maybe think about this. And I looked at the literature and my first degree was in cellular immunology. And you know what? There's no test. There's no test that will help us in 2025 determine risk. Could we come up with a risk score, however? And I think the answer is possibly. And it would involve things such as you see on the left-hand side here. And then, but again, this would have to be a very, very big study. And the point's been made. If you've got a 1% post-op infection rate, you'd probably have to enrich for high-risk people and then decide, on the odds ratio related to, let's say, whether they're on steroids or not, whether they're having chemotherapy or not. But, it's not that easy, is it? Because, some of my colleagues do all these fabulous athletes and footballers, and they're young and they're super, super fit. And of course, they're young and fit and therefore they don't get infected. Well, that's not true. And there really is a very large amount of body of evidence now that intensive exercise is unbelievably stressful and really immunosuppressive. So Ray Williams died last year, I think. He was a martial arts, really good at martial arts, 18, perfectly fit. The chap on the right was a paratrooper in the US Army. The left-hand quote there, I don't know if Marina Morgan's on this call, but she's seen a lot of these. These are young kids who are really pushed very hard for SAS, SPS training, and they're really stressed. And when they get staph, it wipes them out. We talk about age. The lady on the right is 95. The gentleman on the left is much, much younger, but is paralyzed. And we now know that gut microbiomes don't follow age, they follow health. in that the lady on the right has probably got the gut microbiome of a 20-year-old athlete, and the chap on the left has got the gut microbiome of somebody in a care home with dementia. So watch that space, because this is going to be important. Let's just turn to macrophages for one moment, literally. I was very interested in this paper. This is to do with old and young mice, and you can have a look at the paper, but what they essentially did was some metabolomics on macrophage differentiation in mice whose legs are fractured, and you watch the callus come along, and of course old mice have less callus and more cartilage. And this relates absolutely to the phenotype of activation of the macrophages in those tissues. And it's interesting, we talked about obesity earlier, or Michael talked about obesity. The type of macrophages that exist in obese people, because obesity switches them on, are exactly the macrophages which tend to inhibit healthy callus formation and proper bone healing. So again, watch that space. There's some molecular reasons for this. And of course, if there are molecular reasons, maybe we can do something about it. So I'm going to stop in 20 seconds just to say, look at these figures. Look at these figures. If you haven't read this book, please do. Halsted was an extraordinary physician who was really, really tough, but he discovered cocaine, and he trained a whole generation of doctors on cocaine, and some of them took too much and some of them died. He got worried himself and therefore started balancing it out with morphine and continued to operate. And his results were fabulous. And all he said was, this is how you do it so you don't get infection. And you know what? There are no data on this. It strikes me as totally obvious that if you leave a hematoma behind, we heard about tranexamic acid, that's going to bias you towards infection, et cetera, et cetera. And I personally would like to see a trial where it might have been done, but I can't find it, on CRP on day 2 in the same elective arthroplasty and relating that to post-op infection rate. And I suspect there'll be a correlation. So there we are. So just to finish, orthopedic surgeons, this is a homunculus. What they do is they like to act. And as we know, they're more intelligent than the anaesthetists, which is very interesting, and they're much stronger. Just to say, this slide was actually stolen, I think, from my colleague Jeff Ridgway originally, who thought he'd do that, Jeff Scott rather. And I'd just like to thank these 4 people who mean that today I've been talking to you. Thank you very much.
Thank you very much, Vanya. That was a fantastic talk, very entertaining. And it's given us all a lot to think about there. It's also great to know that we can now blame our anaesthetist as well as the patient for PGI, so that's good. We had spoken before about what we don't know in PGI research, and I was wondering, what do you think are the main reasons that these gaps have persisted? Is it our research methodology? Is it our diagnostic tools? Is it because we don't understand enough about the host immune response?
Now, how long you got? Yes. So my personal view is that the whole of the trial industry is dominated by pharma in the form of randomized controlled trials. And I do not believe it appropriate, having done a big one myself and learned from it. I don't believe that for the kind of questions that we want to answer in orthopedic surgery and infection, I don't believe the randomized controlled trials are the right way forward, because they're, drug A versus drug B, that's easy. We've got a far more complex setup. And I think we should be looking more and more towards very adaptive trials, in the future. But randomized controlled trials, I think, will never answer the question, especially if you've got a 1% incidence of that signal that you're looking for in the first place. Yeah. And as for the science, I am pretty convinced that if you've got a better microbiome and you're healthier, then you're going to do better. And we know that's true, because if you come to the operating table already on antibiotics, your risk of SSI is higher than if you come to the operating table antibiotic free. And that's because you screwed your microbiome. And I think that's telling us a lot.
Mm-hmm.
And the trouble is, pharma ain't going to fund the trial, are they? That's the real problem.
We've got a question here from Mike Reed. He says, what can be done to improve albumin? We measure it, but we can't fix it.
Well, yes and no. There's a 10 to 15% rate of malnutrition in the United Kingdom that's completely that we don't kind of realize. You know, if you're a little old lady and you're on tea and biscuits and you fracture your hip, you know, you may have a low albumin. You can, of course, fix that, although you probably couldn't unless you could delay the operation. You're right, of course, in that you can't always fix it. And of course, very often the albumin's low because you've got some terrible comorbidity. But you can certainly, if it's low albumin simply because you're malnourished, then you can certainly fix that. And if it's an elective procedure, I would certainly try and sort it. The trouble is who's going to pay for it and where is the system optimizing your patients? So they'll cost less to the NHS because you get less infection, but who pays? Because it won't be directly related. And it's the age-old problem of siloed thinking in the whole NHS economy.
Fantastic. Thank you so much again, Vanya.
Okay, you're welcome.
So just before we go on to our final speaker, I just want to take a moment to thank our sponsor for this webinar, which is Smith & Nephew, and highlight one of their revision hip product lines, the REDAP system, which we use a lot here in Vancouver. Get my slides to progress. There we go. So on the stem side, this is a monoblock taper-footed design that's very versatile, straightforward to use, and it's designed to give a lot of stability to prevent subsidence. I trained with modular stems in Glasgow, however, I found this a very straightforward transition. The use of monoblock stems in revision arthroplasty is certainly not something new. It's got a long history of use in this department, and that's partly due to concerns with modular junction failure, which are rare but do occur. The intraoperative flow is very streamlined. You distal ream the stem diameter, leave the reamer in the canal, proximal ream, and apply your body for your trial, and then insert the definitive stem. So looking at the literature for this, the NYU group demonstrated minimal subsidence, showing the implant to be very stable. And these levels of subsidence are lower than other similar stem designs, and that's also been replicated by other studies in the UK. The NYU group again showing that REDAP demonstrated lower subsidence compared to modular stems, regardless of Periprosthetic defect classification. So moving on to the acetabular side, the system aims to cover most eventualities. It's a highly porous 3D printed cup with 80% porosity in the surface, and it grips very well, as you would expect for a revision shell. However, there's also the option of locking screws if you feel the bone quality is especially poor and you want better initial stability until on-growth occurs. There's also a range of augments to cover the majority of bone defects, with some nice touches like Steinman pin holes for initial placement and cement ports for when you unitize the construct. And you can also use locking screws here as well. There's the usual array of options for liners, and you can use a 36 head with a 50 cup, as well as dual mobility and constrained. The OR30 dual mobility has an oxinium liner with a central peg, making it almost impossible to malseat the liner. And given the potential for corrosion between cobalt chrome dual mobility liners and titanium shells, particularly when they're malseated, an oxinium liner that can't be malseated effectively removes this issue. So in summary, I found this system allows for a streamlined workflow. It's very versatile, covers the vast majority of revision scenarios, and minimises the potential issues associated with modular stems and dual mobility cups. So moving on to our last speaker now, it's my pleasure to introduce to you Professor Mike Whitehouse from Bristol. In addition to a complex clinical practice, Mike has contributed a huge amount to the PGI literature, including great studies like the INFORM trial. He's also in the Research Committee Chair for the British Hip Society, Executive Committee for the NGR and Board Member for the Bone and Joint Journal. Mike is going to be discussing the very interesting topic of whether there is enough evidence to support single-stage revision. Over to you, Mike.
Thanks very much, Ian. And yeah, as Ian says, I like to get around and bug people, essentially. So yeah, I'm going to touch on a few things here. And obviously the INFORM trial features fairly heavily in this, and some more recent evidence that's beginning to emerge. And the question I was asked is there enough evidence to support single-stage revision? So by way of conflicts of interest, the reason my university like me is I go and ask lots of people for money in the forms of grant funding, and it goes to them, not me. So if you want to take a screenshot, obviously these talks have been recorded, but the evidence sources that I'm going to cover in the talk, a lot of them are summarized in these three sort of web pages. Probably most interesting, sort of practical for day-to-day practice, the INFORM group's evidence and guidelines with some patient information there as well, rather than just us talking about things that fascinate us as clinicians. So in terms of bias, am I biased about whether we should do single or two-stage now? Yes, I am. But I like to think that bias is informed by evidence and what we've done to push this forward rather than just opinion. I will confess, I have done a two-stage revision in the last 5 years. It was a patient that had bilateral infected hip replacement, so I did a stage 1 or 2 on my list. On the following week, a colleague of mine did the single stage on the other side, and then I came back and did the second stage on the original side 2 weeks later. So I will say there are some circumstances where two-stage can still be justified, even in my practice with my bias. So by background, the INFORM study started around about 2014, and when we were looking at this, we were looking at problem of prosthetic joint infection. As Mike said earlier, it's a problem that's never going to go away, and it is one that is stubborn about coming down. At that time, the evidence from the NGR suggested around 0.9% of primary hip replacements would be infected or treated for infection, rather, in the NGR data set within 2 years of surgery. And obviously it leads to severe pain, disability, increased risk of death, big healthcare expenditure, lots of resource consumption, and it devastates our patients. We formed a patient group to support us in delivering this research, and 2 of the patients on that group had both prosthetic joint infection and cancer, and both of them said the prosthetic joint infection was worse to live through than the cancer. Most undergo revision, but not all. And this was certainly noticeable in terms of the recruitment to the INFORM trial. And single and two-stage strategies were the most common forms of revision. So at the start of the trial, we set out to kind of establish what was going on. And this was NGR data from its formation in 2003 to 2014. Two-stage was still the bulk of the treatments recorded within the National Joint Registry. Obviously, that's not capturing antibiotic suppression. At this stage, one stage also included DARES with modular exchange if things were being recorded properly, because revision in the NGR is defined as anything that adds, removes, or modifies an implant, with a small minority treated with excision. So at the beginning, we set out to look at the rates of reinfection. So this was part of a program grant. And you do program grants because you haven't got all the answers you need yet in order to do a trial. So standard orthopedic hat on at the start, we thought we'd go in and we'd see what the difference between reinfection outcomes were between single and two-stage, and we'd set out to probably try and power a trial on that. So we found out there was no difference in reinfection outcomes between single stage and two-stage from the evidence that we could gather from the literature. But this evidence was trying to find series that were either exclusively single stage or exclusively two stage, and bring those together. Now, you may see them published as such, but as I've just said, you might believe that I only do single stage because I talk about it so much, but even I do a two stage occasionally. So clearly not everywhere has pure practice in this respect. So then Sitor Knutzel, his colleague mine who's in Bristol, he's over in Canada now. Unfortunately, we lost him and I haven't been able to tempt him back yet. He set out to do this, what seemed like an impossible mission. So this is an individual patient data meta-analysis. So that involves contacting all the authors we found in those original studies, so 44 different sets of authors from different units, and asking them for all the data they had on their single and two-stage patients that had informed what went into their published series. We invited more than 44 were the ones that replied, and we managed to gather data on 1,856 patients. Now, if you bear in mind, in terms of kind of evidence and infection, the Zimmerle criteria were based on about 40 odd patients. So this is a huge data set in this respect. And we looked at reinfection rates per 1,000 person years of follow-up, and we found that actually that suggested that it may actually be in favor of single stage. So this was good evidence for us to go out to the community and suggest single stage was an appropriate thing for us to test against two-stage revision. So when we thought about the outcome, so could we define this as a reinfection outcome for this trial? Well, it's difficult to define. One of the questions that we got when we were sort of submitting publications was, what criteria have you used to define it? Which set of criteria? My answer to those reviewers was normally, which version of the criteria would you like me to have used? Because during the life of this project, they've changed 2 or 3 times each. It's hard to measure. Okay, so obviously, if you're reliant on samples from a joint, that means you've got to go and sample a joint. Not many of us are willing to go and stick needles or sharp things into a previously infected joint replacement where we think we've managed to treat the infection. It's poor evidence of difference between strategies in terms of reinfection outcomes. So we went to our patients and asked them what mattered. And as part of that, they said to us, we don't care if the CRP is up. We don't care what your lab tests are. We care about how we're doing. So we performed something called a discrete choice experiment where patients choose between options over hundreds and hundreds of different questions. And we found the strong message was that patients wanted a surgical option that resulted in no restriction on engaging in their important activities. Second most popular thing was a shorter time taken from start of treatment to return to no limits on activities. Then they wanted fewer no side effects from antibiotics. And then their fourth preference was having only one operation. So again, this made us feel good. We've got justification to do this trial. So we designed an RCT, and this was just in hips. The funder originally said, yeah, okay, well, you've asked to do hips and knees. Prove you can do it in hips first, because we think that knees may be more difficult to do. And they were right. So this is pragmatic. We weren't telling people what they should prescribe antibiotic-wise. We weren't sort of being prescriptive about exact sort of surgical technique. So this is where that noise comes in. And as Vanya was saying, this is why surgical trials are difficult to do and difficult to interpret. It's international. So when we opened this study, we thought we'd be able to recruit from 4 centres. I'd like to point out I wasn't responsible for that assumption. We weren't. So we ended up with 14 centres in England, Wales and Sweden. The NIHR, the funder of this study, wouldn't let us open in Scotland, but would let us open in Sweden. That tells you a lot about research funding. So, as I say, opened in 3 different countries, and we recruited patients over the age of 18. And the criteria for inclusion was that the treating clinician had to believe there was a prosthetic joint infection that justified doing a single or 2-stage revision to the patient. And the patients felt this was appropriate because that's the decision-making process that led to them having a further operation or not. So we compared interventions, and we rapidly found out that even surgeons can't agree amongst themselves what is a single-stage revision or a 2-stage revision. We had people saying, oh, I always do a 2-stage revision. I go into theatre, I take everything out, and while everything's cleaned up, I go away and have a cup of tea and a chat with matron, and I come back and then I do the second stage. So we actually thought about this, and if you have it done under 1 anaesthetic, it's a single stage. And if you have it done under 2 anaesthetics on different days, it's a 2-stage. So in terms of outcomes, because of our patient input, we went with the WOMAC global score, 18 months post-randomization as the primary outcome. And we collected, as you can imagine, for a trial like this, a host of secondary outcomes. So the subscales of the WOMAC, the WHO's and the OHS, anxiety and depression scale, always an attempt in orthopaedics to try and blame the patient for their outcomes, brief pain inventory, 20-meter walk test as a measure of function, complications, reoperation, intraoperative events. And obviously health economics are important because this is an expensive thing to do no matter what, but there can be variations in that expense. So primary outcome qualities at 18 months, then the secondary outcomes, the EQ5D, health-related quality of life score, and the costs both from a provider and a societal perspective. So the statistical analysis, standard stuff really for this kind of trial. So intention to treat, predefined statistical analysis plan, and these are the kind of statistical models that you see when you've got to account for baseline differences within trial populations. So recruitment, what we found out is screening data in this kind of trial is really hard to interpret and is essentially, to my mind, pretty much useless. So one of our sites screened every single new referral to the orthopaedic clinic. So we ended up with 506 patients that weren't PGI. In fact, quite a lot of those hadn't had a hip replacement. In the unit I work in, we screen the patients in the hip prosthetic joint infection clinic. So there were certain entry criteria to already be in there. Quite a lot of the patients, of those that did have PGI, quite a lot were felt to be appropriate for DARE, antibiotics and monitoring alone. We had a group where it was deemed impossible for them to be treated with one of the two arms. That was 124. One was unable to give consent. So of 186 eligible patients, interestingly, from that point forward, only 8 of them fell out at that point because of a surgeon's decision about treatment. 20 of the patients fell out because they preferred a single stage. Only 1 preferred a 2-stage. Some of them wanted their surgeon to decide. A couple didn't want to participate. And in one, we didn't have a randomization person around. So what we see here, 2-stage on the left, single stage on the right. And in both arms, we lost a couple to withdrawals. And in both arms, patients died. Okay, so it reflects the condition that we're treating here. So in terms of results, what did we find? This is the primary outcome measure. And as you see, we set out to see if single stage was superior at 18 months, and there's not a squiff of a difference. All we did see was that there was a significant difference at 3 months. Now, to couch that in appropriate terms, some of the patients in the 2-stage group had not had their 2nd stage reconstruction at that stage. So I was unsurprised to see that there was a quicker recovery in the single stage arm, and some of the patients were lagging behind in the 2-stage group at that stage. Looking across all those other secondary outcome measures, so it switches partway down because we scored all these on their scoring scale. So for the top kind of one there, and for the first list of secondary outcomes, single stage preferred on the right-hand side. For the bottom ones, it's on the left. But you can see all those lines quite clearly cross that line of no effect. So no difference between single stage and 2-stage for those. However, surgical complications, and this is capturing all surgical complications, so things related to the surgery, that includes blood transfusions, DVTs, PEs, prolonged hospital admission, 57% in the 2-stage group versus 41% in the single stage group. Looking specifically at intraoperative events, 27% in the 2-stage group, just under 8% in the single stage group, and a shorter median length of stay in the single stage group, but not significant difference in terms of that length of stay. So how about the health economics? So QALYs, a higher score here is better. They were higher in the single stage group. And when we looked at the costs from the healthcare provider, so the person that's paying perspective, single stage cost £36,256 over 18 months compared to £46,312 2-stage. So £10,000 saving if you did a single stage. When you add in the societal costs, that's the stuff that happens out of the immediate sort of hospital admission, healthcare environment, and antibiotic prescriptions. Again, difference just under £10,000. In terms of incremental net monetary benefit in favour of single stage, again, from these perspectives, different ways of slicing up the health economics, preferred single stage. And a good willingness to pay threshold certainty is around 60 or 70%. So these are smashing it out of the park. These are as certain as you get in health economic world that single stage is a more cost-effective option. So this was the first RCT of single stage versus 2-stage revision for HIP PJI. Single stage was not superior for the primary outcome, but did give quicker recovery, fewer operations, fewer complications, and was more cost effective. So we concluded we should increase the use of single stage. Now, obviously, it's a team effort doing this work. Lots of different names on there. A few of the people are on this call. And to be a surgeon and get your name on there, you had to recruit more than 3 patients. So well done to you, you people. You actually allowed us to do this work. So how about other things? So in the USA, in the kind of early part where we'd set this up, we saw this trial coming out from Tom Ferring's group that was going to be looking at 1 versus 2 stage. So we did approach them, see if they wanted to combine forces, but they decided not to. They were doing hip and knee together. Now, for me, that's a bit of an issue because you can't turn up with your infected hip replacement and have a single stage revision of your knee and expect there to be a good outcome. So really, this is about sort of combining the numbers to try and get that sample size up. So they set out to do a non-inferiority RCT of hip and knee combined for chronic PJI, and they used the MSIS criteria. It excluded patients with that had infected revisions, so these are infected primaries, fungal infections, immunosuppressed, and patients where primary closure can be achieved, so more in the knee group. Interestingly, about 1/3 of the patients in this trial, I believe, are hip and 2/3 knee. And they use an outcome of marker of success of no reoperation for PJI. Now, this is first presented at ARCUS. This is presented as an interim data analysis. So of their 321, 16% lost follow-up, 8% not completed at that stage. But again, looking at the 245 there, their 1-year success rate, 98% in the single stage arm, 94% in the 2-stage arm, considering reoperation for reinfection. Interestingly, they found similar rates of adverse events between them. For those interested in contributing, Roadmap's a big trial that's been led by Australia. We're just looking to set up a UK arm at the moment, looking to recruit 2,500 patients with 3 silos of treatment. That we're comparing DARE versus revision for late acute PJIs, rifampicin or not as an adjunctive antibiotic, and 6 weeks versus 12 weeks of antibiotics after revision. If anyone hasn't got tired of trying to do big complicated trials in infected joint replacement yet, this is your opportunity to carry on contributing. Thank you very much.
Thank you for that superb presentation, Mike. The INFORM trial is a fantastic body of work, so congratulations on leading that challenging project, as you say. Listening to you talk about your own bias, I was wondering, are there any factors that would make you choose a 2-stage over a single-stage revision?
So basically, when I go into a single stage, essentially, again, it's a team effort. So part of my kind of decision-making to complete a single stage is around feedback from my anaesthetist. So, if they say, I'm only halfway through the debridement, they say, this patient isn't doing well, when are you going to be done? Then I'm saying, do you want me just to complete a debridement? And then we get the patient round to HDU, ITU, and come back another day to do this. So I will bail partway through if I need to. I think, when I thought about it, I always thought about it in terms of the context of how often did I go back to do a second stage? And I was really glad I'd left it. So the 2 situations for me there would be, it needed another, they were going back to theatre. Similarly, you can do that with a single stage. Part of the INFORM work, we found that the number of operations received in the 1-stage group was 1.2 on average per patient. If you look at the registry data, and in the 2-stage group, it was 2.4. So, the 2-stage group don't only get 2 operations, and the 1-stage group don't only get 1 operation if you look at population level. The other circumstance is really for sort of big custom implants. So if you've got big acetabular defects and you're thinking, I want to do my debridement before I make the definitive call, get my scans to get that custom implant. Other than that, the fungal infections, I think, are the ones where, we don't have a good answer, and, doing those. But they've got high risk of failure anyway. But even I'm not brave enough to do single stage on confirmed fungal infections yet.
Yeah. Something you touched upon there was, are we using the right outcome measures when we assess single versus 2-stage? Because we often discuss infection control, but should function and patient-reported outcomes be at the forefront of defining success?
I mean, that's the conclusion that we came to talking to our patient groups and doing those discrete choice experiments. And quite often, think about these patients, they turn up, see us, and they've had a miserable time. They may have had multiple attempts to try and sort of treat this that hasn't worked. Some turning up with colostomy bag on high output discharging sinuses. And for a patient that's been through that, quite often they're like, if you can just stop me having to have further operations and stop this stuff coming out my leg, and I don't have to be on horrible toxic antibiotics, they consider that to be a success. And really talking to them, they're like, if I haven't got pain and I can do what I want to do, then I would consider my treatment to be a success. I think it's a complicated picture. I think, the truth is you need to capture a range of outcome measures. And I think, which primary you go for, you need to justify the decision that you're making with that. But, kind of as we've discussed before a few times, and tried to work on the inconsistency in reporting across the literature makes combining this really hard work. And I think we could do with a core outcome set to define it.
Yeah, watch this space. So a couple of linked messages coming through here. Firstly, from Tamsin, what about difficult to treat organisms such as fungi, which I appreciate you've mentioned, but also resistant bacteria? And Vanya says the same thing about Pseudomonas being a professional biofilm former. What's your thoughts on those resistant organisms?
So, again, within an RCT, you will see patients that may have mysteriously disappeared out the trial, and that reason not be entirely obvious. I personally did treat patients in this trial with MRSA, and I treated one patient with Pseudomonas in it. I think tackling the biofilm, critical. I think the surgical component of that is really important. And what we don't have in trials like this is a measure of adequacy of surgical debridement. So again, I think sort of multi-pronged. Personally, I didn't want us to get into kind of complicated scenarios in terms of microbiology, because let's face it, we only know about the bugs we know about. And, it's not uncommon to find out when you've been in for your second stage, or, kind of the samples that you get back after your treatment, despite sampling it, kind of in a robust manner beforehand, you find out that there's other bugs involved that you weren't anticipating. So I didn't want it to become for staph and strep PJI, this is a thing to do. But I've absolutely no doubt that some patients were probably excluded by surgeons who were kind of like, that's a tricky bug.
Superb. Thank you again, Mike. Well, that brings the session to a close very nicely. Thank you to everyone who joined us this evening. We greatly appreciate your support for the Society. A special thank you to our sponsor, Smith & Nephew, for their generous support. And I'm personally very grateful to our speakers, Michael Neufeld, Vanya Gant, and Mike Whitehouse, for offering their time to deliver those superb presentations. I look forward to welcoming you all back in May for our next webinar, which will feature some of the biggest names in infection research. But until then, thank you very much and good night.
Have a good evening. Cheers.